Hi, everyone. Good evening. Thank you for being here. Really, thank you for choosing to spend an hour of your evening in conversation about something that's no longer abstract, right? It's certainly no longer optional too for us as clinicians, I think. So, on behalf of the New York ACP Climate Change Task Force, welcome. You may already know this, but our chapter exists to support us clinicians across the chapter and beyond in advancing clinical excellence, education, leadership, but also advocacy. And tonight's program reflects that mission directly. I think we all know this, but we're here because climate change is really not just an environmental issue, right? It is a clinical issue, it's a systems issue, it's a health equity issue, and we're seeing it. We're seeing it in the hospitals, we're seeing it in in the office, in the exam rooms, and in the communities that we serve. So really the purpose of the event tonight is to move beyond awareness and hopefully towards clarity about our role as clinicians, our responsibility, and perhaps our practical opportunities uh, as physicians. So I'd like to begin by having our faculty panelists to introduce themselves. So they all bring uh, both deep clinical expertise and a thoughtful perspective on how physicians can be a change agent, right, within their institutions, within their communities. And I'm really grateful for your leadership and for joining us this evening, of course. Uh, so with that said, our very first panelist is Dr. Matt Hollon. I'm gonna let Dr. Hollon introduce himself.
Oh, great. Thank you so much for having me. So, yeah, my name is Matt Hollon. I'm a internal medicine physician and medical educator in Spokane, Washington. And most of my career has really been in really across the UME, GME environment with a focus in my own clinical practice on primary care. And I am the past governor of the Washington chapter of ACP and a current regent for the college.
Thank you so much, Dr. Hollon. And our next panelist is Dr. Douglas DeLong.
Hi, everybody. Doug DeLong. As a PGY 46, I'm mostly retired at this point, but still get to teach one day a week to smart young residents. I live outside of Cooperstown, New York, and work at Bassett Healthcare. Um, I've had the opportunity and the great privilege of um, having multiple roles within the ACP. Most recently, as and now the chair emeritus of the Board of Regents.
Thank you, Dr. DeLong. And our next panelist is Dr. Kerim Odekon.
Oh, hi. So great to be here and so nice to see some of my colleagues also attending. I'm Kerim. I'm a primary care doctor in the resident clinic at Stony Brook Medicine in Long Island. Before primary care, I was the city planner for the city of New York, doing housing policy and finance for almost 8 years. So it's been a kind of circuitous route. And my activism around climate change, I feel like, brings into many parts of my past life in government and my love for patients in my current career. So it's a good fit.
Thank you, Dr. Odekon. And I'll be your moderator for tonight. And you may have already seen the agenda. There are some questions in there that we're going to go over together. Hopefully, we'll have time to cover all of the questions. If not, of course, we also want to make sure that, we hear your questions. So feel free to send your questions on the chat box. I'll be on the lookout for those. But otherwise, we're going to go over the questions that we have. And with that, we're gonna transition into our large panel discussion. I'm not sure. I think Isaiah, you might have something next. Oh, all right, perfect. The large panel session. So So I'm looking forward to this, thoughtful and discussion. So we're gonna begin with the very first questions here. How do each of you define the idea of clinicians as change agents, right, in climate action, and what makes this especially relevant to the internal medicine physicians? Should I start with Dr. Holland, perhaps?
Yeah, I can lead off. That's great. Yeah, so for me, this is really embedded within the 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 broader sense of responsibility that we have as physicians to our communities and to public health and to advocacy. And for me, it was really actually through the American College of Physicians that I first got exposed to advocacy and um, I used to be a bit of a political cynic and once I got involved, at that time, the governor of the Washington chapter, Carrie Horowitz, really got me involved in the Washington chapter and advocacy work, both at a state and national level. And it's just this realization that we have a place of privilege in society as physicians, and we are a trusted voice. And I realized that, perhaps as as sometimes as disparate worldviews as politicians sitting across from me might have, they actually are trying to do their job as well. And politics is the act of self-governance, and it's not a dirty word, right? It is actually this this process, tedious process of sausage making. It's not doctoring. It's not like giving a medication to someone with high blood pressure and seeing their blood pressure come down. It's you gotta be there and be engaged. And so for me, it's really rooted in our professional responsibility to advocate for our patients and for public health. And for me, the Venn diagram there was my longstanding and deep roots in environmentalism, dating back to my work as a student on WashPERG, Washington Public Interest Research Group, was a real early introduction to me to environmentalism. So, so those those principles, that core principle of physicians as advocates and our responsibility, plus my long standing interest in environmentalism, is really what brought me into the realm of really wanting to serve as a, a, a change agent in climate action. And it's particularly relevant, and I'll let Dr. Odekon or Dr. DeLong speak maybe more in depth about it here. But I think for internal medicine physicians, we take care of so many people who are potentially affected by climate change that it's whether it's older people with respiratory disease or chronic kidney disease and heat exposure, or poor in the West, we really, with forest fires, we really struggle in summertime around air quality. Those are this is like front line for all of us as internal medicine physicians.
Thank you. It's really just empowering to hear that as clinicians, sometimes, when we moved into the advocacy kind of realm, feels like there's really no agency. And from what I hear is that, you do have the agency and you can actually enact change. So thank you for sharing that. I want to hear from the other two panelists as well on this first question. Dr. DeLong, perhaps first.
Yeah, we heard Matt talk about they use the word trust. And for me, the answer to this question has to do with the etymology of the word physician, which is teacher. And as internists, a bulk of internal medicine doctors, having a real relationships with their patient gives us a unique opportunity to have these conversations about what is the mother of all public health issues out there. So we really, not only do we have the opportunity, but I would encourage everyone to take a look at the ethics manual from the ACP, because in addition to have the opportunity, we have the obligation actually to have these conversations, because it does affect the health of all of our patients.
Really agree with that, and that's a really good way to put it. It's not just an opportunity; it's actually an obligation. Yeah. And I want to hear from our last panelist, Dr. Odekon.
Yeah, I mean, for me, the idea of, as a clinician, getting involved in climate change advocacy was a little bit circuitous. I started with garbage. Near my house is one of the largest active landfills in downstate New York. And it's also next to the community with the lowest life expectancy in all of Long Island, which is 3 million people. And, the life expectancy can range in this community in the low 70s compared to other places out east where it's high 80s, low 90s, actually, in a place like Shelter Island. So I started thinking, like, you know, what is going on here? And I started looking around and I started mapping all the various polluting industries that encircle one community. And in that, I saw, there's a giant, you can't miss it. It's a giant power plant, fossil fuel burning power plant, one of the largest fossil fuel power plants in New York State. Emitting 1 million pounds of CO2 a year, just on top of a community with the second highest asthma ER visits in all of Long Island. And so to me, and a lot of our patients actually, our clinic is not near this community, but a lot of our patients actually live in this community with respiratory issues. And so as I started talking to people, it was, I felt an obligation to get involved, because I think as physicians, people trust physicians. They trust us in the doctor's office, and they trust us outside of the doctor's office. And so in that, it was there was a very clear path from the conditions I see in my office to the conditions that entire communities are suffering with. And so that kind of I can talk more about it, but that kind of kicked off my interest. And it was very clear that the same drive that, pushes us to do good in our exam room is there when we leave the exam room.
Yeah, wow. You observe the community, you saw what was happening, and it really speaks about how you are a change agent, right? And I think really being an internal medicine physicians, we're sitting at this intersection of complex chronic disease, as Dr. Hollon mentioned, vulnerable community and populations, and policy, so. I think that positions us uniquely and powerfully in climate action conversation. We're gonna move on to the next question. Um,
And we're trained in complexity, Evan. I think that,
yeah,
internal medicine doctors are trained in complexity, and clearly this is a complex issue with a lot of, um, you know, uh, uh, just a lot of different aspects to it, and we learn to communicate complexity to patients. So back to what, I think uh, uh, Dr. DeLong was sharing with us, that piece about communicating to people is really important, and the trust that we have in physicians as teacher, internal medicine doctors are good at this.
yeah, exactly. This is exactly what we do. Yeah. Um, and it's really just, I think, I'm hoping most of you who are here probably don't need to kind of feel convinced that, this is already out there in the community or perhaps even in your practice. But I do kind of want to perhaps listen into one or two examples. You've heard from Dr. Odekon a little bit about how it's impacting, his community. And it is impacting our patients in many, many different ways. It's very complex, right? And we're seeing that. I know that the other can already share a little bit. Maybe Dr. DeLong or Dr. Holland, would you like to share an example on how this has shown up in your practice or community as well?
Sure. Let me just first of all say that everybody on this call is already seeing this.
Mhm.
We know from small particles and air pollution, ozone, just something. The wildfires, because Matt, that affected us here in New York State as well. We can all remember the mornings when the sun was this awful red, burnt orange thingy up in the sky. It was just really bizarre. But we're seeing people with heart disease and chronic pulmonary disease and diabetes, and all of these things have a piece that's climate related, although it's probably not so obvious. But I'll give you one that I see a lot that is much more obvious. So vector-borne diseases is one big piece of climate change. And where I live in upstate New York, 20 years ago, 25 years ago, we did not have Lyme disease. Now, in the summertime, if somebody comes in with a flu-like illness, that's Lyme disease until proven otherwise. And in addition, we're also seeing more anaplasma now and babesia and all these tick-related illnesses that are clearly related to the warming climate, which allows the ticks to thrive over winter. And it's just this vicious cycle. So there's one really, really in your face one.
Yeah. And even sometimes when it's in your face, like you mentioned about the orange day, right? In the summer. If you live in Northeast, you probably remember this from the Canadian forest fire, like two years ago or 3 years ago. And you really, this is part of the complexities, like, labeling what's so obvious and, really linking that with climate change and the patient's health. And and it gets even more challenging for things that are way more complex, the ones that you just mentioned, right? Tick-borne disease and there needs to be more than one jump to get there. And it's really an important part of what we do to kind of really communicate that. Yeah. Thank you for sharing that example. Anyone else want to share anything before, or we can move on to the next question? All right. Um, And we talk again, I think this question is a bit repetitive in some ways, right? We talk about the tick-borne disease. I wonder if there's anything that comes to the panelist's mind. But I'm also just gonna kind of, thinking about the tick-borne disease and climate change and how I saw this like meat allergy that can be acquired from a Lone Star tick, right? Called, I think, alpha-gal syndrome or something. I've
Alpha-gal.
right, never even seen myself. I was like, yeah, this is the kind of stuff that is very complex, of course. It perhaps may not be the first thing that we're gonna use as a poster case for climate change, but it is affecting our patients. So I think that the bottom line is affecting our patients and our community. But what are perhaps some of the other more common stuff that we don't think about that might be climate related health issues that you encounter in your practice? Dr. Odekon, perhaps you want to chat a little bit more about this and what you saw in the community?
I mean, just the preponderance of, and it's not just climate. There's the climate perspective. There's the PM 2.5 tiny particulate matter. That it's often hand in hand with greenhouse gases when we burn fossil fuels. The comorbid pollutants and so, again, the preponderance of lung disease and asthma. We also have to think about all of the extreme weather that we're having. I have unhoused patients right now, and when there's 2 feet of snow out, I can only think, what are they doing? And then same with the heat waves that we have, the extreme storms. I mean, I live on an island that is, constantly under threat from where from sea level change, that we're actually tearing down homes on the coast to have a buffer area. And often in those communities, those are like working class communities like Mastic, New York. It's not the Hamptons where that's happening. Well, actually, it is happening now in the Hamptons.
I think we don't even, when we say most common climate related health issues, like this is one of the challenges, I think, in communicating the magnitude of impact of extreme heat events is actually a really, it's a kind of tricky thing to measure, and it's ultimately measured epidemiologically. There's the sort of classic study was the Chicago heat wave, where they, looked at, um, you know, uh, um, the number of expected deaths during that time, and then the number of observed deaths during a time, and then they compared that to the number of deaths that were actually just attributed to heat stroke. And in all of these, right, there's really substantial blips in mortality that nobody's directly attributing to heat or heat stroke, right? Rises in mainly in cardiovascular events, particularly for people with chronic kidney disease. And so it gets labeled as someone, having an MI or something like that. But the mortality rates during these extreme heat events, particularly when you think about susceptible populations over large areas, we're talking about not just 100 people or 200 people, right? But thousands or tens of thousands of people. So that's common, right? And it's affecting all of our patients. So I think a really important principle to remember is the magnitude of impact, the magnitude of exposure to extreme weather events, particularly extreme heat or poor air quality, and the impacts on cardiovascular systems and inflammation that PM 2.5 causes.
That's a really good point. It's very, thank you for that. Really, sometimes it's something so visible that you can see, as Dr. Odekon mentioned, it's an extreme weather events and how it's impacting the patient, the community directly. And sometimes it's very just hard, as you mentioned, Dr. Hollon, right? It's just an epidemiology. It's just, you can't really just link it. They label it as MI, they label it something else. Like, what really comes to mind as an example is like Hurricane Maria in almost 10 years ago, where there was significant short problems with the supply in IV fluids, right? At the time. And that was from an extreme weather event, but no one's really gonna link that with all of the problems that comes from the shortage of the IV fluids. Um, Dr. Oregon, you were going to say something?
No, I was remembering with the potassium shortages, all these things with Maria. I didn't know how much was produced in Puerto Rico.
Right.
Let's not
So,
forget about Sandy here in New York State. That was 2012, not that long ago.
yeah, that's correct. Yeah. And it's becoming more frequent. And I think we're gonna move on to the next question. Thank you for all this, input really. And for people attending, feel free to again send your questions directly in the chat box anytime. We'll get to your questions at the end of the large panel sessions. But the next questions I have for the panelists are in what ways is climate change challenging health system resilience? And we've been kind of chatting about this, kind of a good segue. I didn't even realize this was the next question. And how does that affect patient care delivery, right? We chatted about the IV fluids, the potassium shortage. Anything else perhaps that you want to kind of share this way?
I mean, I think health systems are already not exhibiting the world's most resilience right now. They're taxed. They're at the max. There's in a world of constant cuts and discussions about scarcity. We have to think that what is the incremental cost of all of this? I don't think anybody really knows in terms of how much this impacts our healthcare system and patient care delivery. There are a lot of estimates in Lancet and things like that, but it's nothing to specific health systems. It's very amorphous, which makes it difficult.
Yeah. Thank you for that. And I think this question is kind of, in some ways for me, it shifts a little bit from, when we talk about impact on health system, and I'm thinking about really us two clinicians being affected by this, right? Obviously we care so much about our patients and our communities, but in order for us to deliver safe care, uh, we also really have to look into how climate change is going to impact clinicians, right? There's going to be issues with staffing. There's going to be we're already kind of being, right, squeezed out to kind of do the maximum we can. And whenever there's an extreme weather events, things like that, if our system is not resilient, then there will be problems, right? We always assume, I imagine that, the system itself is only allows for certain numbers of clinicians to take care of certain number of patients. But during all this catastrophic events and things like that, obviously it becomes a problem. Um, During Sandy, perhaps, I imagine during Maria in Puerto Rico, I didn't really see it. But we all seen it during the pandemic, of course, right? How certain system who are more resilient than others are able to respond to it better. So it's really thinking about us as part of that system, yeah. Dr. DeLong, Dr. Hollon, any comments on this, perhaps?
I keep coming back to Sandy when you use the word resilience, because when I was an early governor for ACP, one of the other New York governors from Staten Island, his hospital was inundated with Sandy, and it was because just became a real. And he had pictures, and it was extremely. It was not COVID bad, but awful in a different way. And they lost. Not only did they lose power, but their emergency backup systems were in the basement, where of course they got flooded. So just a real basic engineering no. Um, and I just keep coming back to those pictures. It was just awful.
Yeah.
Yeah,
Yeah.
I think, at a time when the system is already being stressed, climate change is this just magnifier issue, the
Mhm.
unpredictability of it, the magnitude of potential impacts, whether it's in extreme weather events or, the WHO estimates that there will be 1 billion 1 billion climate refugees by the end of this century. And think about the stress on healthcare systems of these vast migrations of humans who will likely be coming from uh, you know areas of the world, resource limited areas of the world, and think about the kinds of stress that that's going to put on health systems at a time when we really have yet to develop. I mean, there's absolutely, there's been incredible progress made in terms of transitioning away from fossil fuel based systems in the world, and at the same time, we really haven't turned the corner yet. And so it's, particularly in this country, we seem to be going in reverse right now as you watch the endangerment finding getting repealed and all of that. And it's the systems are not so it's it's kind of coming at us from all sides. And then there's the whole question about the ways in which this impacts people's sense of hope about the future. I think we see that a lot. And boy, if you all haven't read Howard Frumkin's article on hope, it's a great article. Howard Frumkin being one of the parents of the concept of planetary health, wrote this really article, great article. He's an internal medicine physician, and he wrote this great article on strategies for maintaining hope in the face of what can seem to be a really daunting problem.
Thank you for that. Yeah, we want to definitely. We've been just talking about all the problems that are caused by climate change, but of course, we want to thank you for refocusing on hope, on really what we can do, right? We want to, obviously, everyone here who's attending to leave with that sense of there's something we can do. We're a change agent. We can do something about it. But we're going to move on to the next question because Dr. Holland also mentioned about climate refugees, really, kind of and you mentioned also like, this is a magnifier, right? It is. It's a climate change magnifies everything, including health disparities. And we take care of marginalized communities as internal medicine physicians, right? And how do you think, using the equity lens, any stories, any examples perhaps on how clinicians should approach climate action with that equity lens? Eh, I know Dr. Odekon, maybe you want to mention a little bit more about the work you've done with the community. I know you mentioned somewhat.
Yeah, I mean, I think the question is like how to start engaging in communities that are marginalized. They have existing health disparities. We know this. I think the data that we can use, it's interesting. The federal government actually removed a lot of environmental justice data from the EPA's website. They used to have a tool called EJ Screen. New York State has what's called potential environmental justice area maps, PJAs, where they again they're looking at different demographic factors, and I think that those are the geography in terms of which communities are impacted and with what disparities. I think is there, and there's a reason why the federal government is trying to hide it. Because these are the places that we need to start engaging with as physicians because I guarantee you once we start scratching the surface, those health disparities will be so clear to everybody, because unfortunately they are not distributed equally across our societies.
Yeah, thank you for that. And I think this really kind of comes in like, as physicians, I feel like we really want to advocate for our marginalized patients, from marginalized communities, just kind of part of the ethical pillar of justice. Like I feel like that has been really ingrained during our training. So thank you for that comment. I'm gonna actually move on to the next question here, and we're really gonna shift gears to what us clinicians can do. What are some strategies? And we're all busy. We're all again being stretched, right, clinically with so many different responsibilities. So one would ask, like, this is another thing to add another layer on top of what is already, just being so stressful. So what are some perhaps practical ways that clinicians can incorporate maybe considerations about climate health into what they do every day, into the routine care, without really overwhelming their workflows? Any particular tips or strategies perhaps from anyone on the panelists?
Can throw out one thing that people are already doing, and so it should, it's not adding, one more click to your busy day, and that's telemedicine. A big part of the carbon that's attributed to healthcare has to do with transportation and the transportation of patients. So the more telemedicine that you're able to do, this is having a direct impact on climate change. So you're already doing it. Congratulations.
My colleague, one of my colleagues in the WAMI region in Idaho, Bill Wepner, who's based at the Boise VA, actually published a interesting and helpful paper on telemedicine in the VA system and the benefit in terms of reduction in fossil fuel emissions related to that. So pretty cool. I personally try to incorporate the good for you, good for the planet approach in my visits. I have always loved this intersection between primary care, preventive health, and things that are that are good for the planet. And so that's oftentimes the language that I use. And so those are things like alternative transportation, walking or riding your bike to work or to the grocery store. Good for you, good for the planet. Eating low on the food chain. good for you, good for the planet. And so that's language that I will frequently employ in my primary care practices, where those really wonderful areas of overlap that are both healthful for us as individual humans, and then also importantly helpful for our planet.
Thank you. I think, yeah, if you have the infrastructure and it, really can ramp up the telemedicine, I agree, right? There's a lot of things, savings in the emissions of carbon dioxide and other greenhouse gases there. And really, we've been chatting a little bit about communication. Good for you, good for planet. I will steal that.
I like that mantra. Yeah, it's a great one.
It's
It's great. We love that. Um, so my next question for the panel is really about communications now, and how do you communicate the climate impacts, right, to our patients? But how do you communicate it to, for everyone attending here? I think you all want to start to think about yourself as a change agent within your institutions, and within your community, and you want to obviously be able to communicate all this in an impactful manner to the stakeholders, right? Perhaps it's going to be your colleagues to kind of get another grassroots kind of movement, or perhaps it's to your system leaders or admins in a way that will prompt engagement. And then perhaps you want to talk about, I don't know if you've done a project in the past, a QI, how did you get it started? How do you communicate it? Want to share some examples, perhaps? Doctor, anyone want to?
I mean, I'm just a small example is, when I'm prescribing an inhaler, I'll talk about MDI versus the dry powder inhaler, and talk about, the propellant is that they use for the pump is greenhouse gas, but I never push it, because at the end of the day, I want the patient to breathe well, and so I'll kind of mention it, but whatever is most comfortable for them at this point. Is the inhaler that they'll actually use. All else being equal, I think I would always say, hey, try the dry powder inhaler. But often patients know what they want and what they feel comfortable with. And at this point, I'm not at a place where I don't push anything.
Right, you kind of want to assess and see where they are, kind of meet them where they are, not really trying to force anything.
Even though there was a recent paper in JAMA for the VA, I don't remember which VA system, but showing that there was increased prednisone usage when they switched people over to dry powder inhalers. So it's not a complete slam dunk. It makes sense from a climate change perspective, but I try to take a very patient first approach, and focus my climate change efforts really outside of the clinic more than inside of the clinic.
Mm-hmm. Right. So I'm using that mantra. It's gonna be first good for you, good for patients, before good for planet, right? It's not gonna say good for planet, so it's gonna be good for you in that way.
my answer to this, and I've not always been great at it, because I think sometimes I end up feeling like a broken record, but the answer here, I think, is relentlessly. And I think that is the way that we have to do that. This is the public health crisis of our century. It's not COVID. It will be. COVID may have been, but it's climate change that will be the public health crisis of this century. And I think it's relentless. And even in times where we feel like we're losing, the communication has to be relentless. And I get a little worn out by feeling like I'm a broken record. Oh, here's Dr. Hollon talking about climate change again. And the fact is like that's what we have to do. Because that is the way in which, I think that is part of the way that we have to move the needle. Obviously, it has to be effective communication. I think that's the other piece. But first and foremost, I think it has to be relentless communication.
And I think it's communication for me is not the right word. I think it's really more of education. And that starts with educating ourselves, like hopefully everyone is doing tonight. And then educating our patients in any forum that's available, from the doctor's office to other events in the communities, to letters to the editor, colleagues giving grand rounds, um, participating in the New York ACP Climate Change Task Force, meeting with your administrators and in your hospitals and talking with them. And I have found this actually that they were quite receptive to the idea of particularly going back to resilience and things that they might be able to do, like and changing the anesthetic gases that they use. So there's just lots of opportunities to educate people, and that's what we do.
And that's such a perfect segue to the next question, which is on educations, because clinicians really we often lack formal training on climate health topics. I think that's changing in many different medical schools, but I think there are still gaps, right? So, what educational or perhaps CME professional development programs that you have found to be effective to improve training on climate health topics? Isaiah is on the next slide for this question.
There are people on this webinar that are probably familiar with Project Echo. It started out by a hepatologist in New Mexico who was the only person to take care of hepatitis C in the entire state. And his brilliant idea was to expand his knowledge and give it to primary care physicians, mostly family practitioners in rural New Mexico. Anyway, within Project Echo, it's now become there's a Project Echo for everything, and there's a really, really good one on climate change that I would encourage people to look up. It's been going on several years. They're really right now. I just looked it up. They're really talking more about the sort of the social equity, part of things. But there's been wonderful talks on you name the subspecialty. There's been a Project Echo climate change talk on it.
Thank you. And then if we have that resources, perhaps we can share with everyone later.
I mean, there are so many. I mean, this is a place where whether it's the National Academy of Medicine has a big upcoming session, or the Medical Society for the Medical Society Consortium for Climate and Health is a great resource. Clinicians for Planetary Health is another excellent resource. The ACP itself, although we don't have quite the educational infrastructure, we're working on that. And we certainly have advocacy paths for climate health topics.
So many
good places to start are like the Medical Society Consortium on Climate Health, Clinicians for Planetary Health. Those are good starting places.
Perfect. I hope everyone got the name of that. If not, we'll try to put that in the email after.
Also, the Lancet has a number of subgenres. So there's a Lancet on planetary health. So I review that weekly. It's really a great resource.
Perfect. And to add to that, like New England has the New England Journal of Medicine climate area. Again, it's not like a Lancet, it's a dedicated journal, so another resource for everyone. Okay, thank you. That was very, very helpful. Okay, so moving on to advocacy a little bit. What do you think are the roles that clinicians can play in local, state, or national policy on climate action?
I love this question. I think we have so much opportunity, and there's such a need for physician engagement on state, local, and national policy level. And I think, there are so many community organizations and groups who are actually much more vocal than physician groups on this front. And I think, joining with them, building in the movements that already exist rather than trying to create our own, and meeting communities where they're at and helping them achieve these goals hand in hand, I think is a really an important one. I think, in New York, we're kind of blessed. We have a law in 2019, the Climate Leadership Community Protection Act, CLCPA, which mandates a 40% reduction in greenhouse gases by 2030. This is the law of New York. And so, in terms of what kind of advocacy we can do, the New York State is not meeting its guidelines to get to that point. And I think that in addition to 40% reduction by 2030, it's a requirement that 70% of electricity generated in New York be renewable by 2030, zero emission electric sector by 2014. So these, I think to a lot of people, these in the current climate, we're kind of giving up on these goals. And I think that the exact opposite has to happen, that we have to dig in and join groups like New York Renews, who fought for this legislation at a state level, and try not to allow things to be unwound. And on a personal level, what does that mean? Like I'm a petitioner in a lawsuit against the Department of Environmental Conservation with Earth Justice, Sierra Club, the Brookhaven Landfill Action and Remediation Group, because the state is not living up to its promise. And just, it was just a few months ago, the state missed another deadline because there was a cap and invest program that they were supposed to promulgate the rules on. And the judge said to the state, you have to do this. And in November, the state again petitioned to and appealed this decision. So I think they're 2 years past when they were supposed to promulgate the rules for cap and invest in New York. So there's a huge opening for physicians to make the connection between the policies that exist and the implementation that has to happen to protect our communities.
Yeah, obviously national policy here this is a tricky time for national policy, after we had the most extraordinary steps forward with the Inflation Reduction Act. Now we're having like the most extraordinary steps backwards. I really think for me, this has been involvement in my state medical association and change, and moving the needle at a state level. And so thinking about, and again, obviously you all in New York State are much more familiar with, as Dr. Odekon's sharing with us, what can happen at a state level. But I think as part of our national conversation, encouraging our colleagues to be involved in their state medical associations and really to try and move the needle there. I put in the chat, a lot of states have these make polluters pay initiatives. I don't know if that's true in New York State, and we have a carbon pricing system in Washington State that we've had for a while. So it sort of overlaps. We haven't totally taken this on, but I think if your state does not have a make polluters pay initiative and or law, that can be a good avenue.
Thank you. And I agree.
Local involvement is, I think that's the other place where you really can, certainly in my community, reaching out to your local community, and whether that's being, most local communities now have, some sort of climate adaptation, climate response board. So the city of Spokane certainly does, and communities and local areas have to come up with plans for tree planting and for other, ways to address urban heat islands. And so, and physician voices are invaluable in your local community. So, I would just go to whatever your town or or city website is and type in climate in the search and figure out what's available and sign up to be on your local board, because that's another great opportunity.
Right. Yeah, those are all great opportunities, or perhaps you can rephrase this as obligations. Now I want to look into the Make Polluters Pay for New York State, and definitely, it's we're not gonna. It feels very overwhelming, right, to think about national policy. So we're gonna start small. We're gonna start local, right? Maybe in state, and then as Dr. Odekon mentioned, like, it feels overwhelming maybe to just start something new by yourself. Find a colleague, find someone who's already doing something about it, and join them. And which leads me to my last question for the panel, which is, what would be one specific action? And I think there has been many recommended actions so far here, but one specific action you can repeat what you already mentioned, perhaps that the audience can take this week or month or year, in their own practice, in their own institution, or in their own community to advance climate action in health.
I'll just circle back around and encourage people to look at in their local communities, at their at their town or city or county governments, and see if you can't get involved at that level, at a kind of you know on the ground level. I've found that to be incredibly rewarding way to be connected to my community and to really contribute to policy development, particularly as it relates to again, things like addressing urban heat islands. Yeah, Doug says vote.
Yes, Dr. DeLong says vote. Dr. Odekon.
I would get involved in communities, in your nearby communities. I think that to me, the antidote to burnout is connection. And a lot of people ask, "Oh, how do you do all this stuff outside of work?" We have busy work days, and to those human connections. I was at a protest on my lunch break today. The really to drive me and allow me to sit down and continue to do my work, which is sometimes feeds into other aspects of your life, and we have busy careers, but yeah, to me it's a venue to make it sustainable.
I agree with that. And my one specific action is also kind of an ad for the Climate Change Task Force for the New York chapter, but join us. Send me or Isaiah a message if you're interested to join our New York State Climate Change Task Force. And yeah, become part of our community and we can continue this conversation. But really, I want to thank the panelists tonight. Thank you so much for your expertise. Thank you for sharing your stories. It's really, really empowering for me.